Okay, so here we're it's great to welcome Garret Choby, who's here to talk to us about his experience in Pittsburgh and the skull base unit there. He's going to talk to us about his experience and chat to us about what he recommends for trainees and training programs going forward. So over to you, Garret. How did you end up in Pittsburgh as a skull base surgeon? Where did you start and what was your path?
Yeah, great question. So, I'm actually an original Pittsburgher. So I joke that I've got iron ore in my blood because I grew up in the Pittsburgh area. But how I ended up in Pittsburgh was actually trained in Pittsburgh. So I did my residency training in Pittsburgh, and then I went out and did fellowship at Stanford. So from Pittsburgh to the west coast of the U.S. And then I took my first job, excuse me, actually at the Mayo Clinic in Rochester, Minnesota. So I was there for 6 years, and obviously got my footing in Pittsburgh, which is awesome. And then working at Mayo Clinic is a great place too. A really strong skull-based program, high volume of cases. So it was a great experience there. Sort of getting my career started and really excellent academic opportunity as well, which was really nice. And really got to sort of get your feet thoroughly wet, dealing with people from across the nation and across the world to come there for their care, a lot of complex tumors and those kind of things. And then I was fortunate enough to be recruited back to Pittsburgh in 2023. So had the opportunity to come back and join the group in Pittsburgh. And, Pittsburgh's like no other. So it was great to come back home to the city of Pittsburgh, but also to be with the group in Pittsburgh who's just, in my opinion, really unparalleled group that I had the fortunate opportunity to join.
And what was it that attracted you to skull base surgery in the first place? Because as an ENT surgeon, it's only a very small part of our training. So how did you end up there and how did you get all that great experience?
Yeah, so it's a small part of ENT training for the most part, but I will say when you train in Pittsburgh, you get a firsthand view of sort of what it's like. So it's hard not to be attracted to skull-based surgery when you're a trainee in Pittsburgh, I would say. What I love the most is working in a team-based setting. So we do all these cases together. It's a unit that really sort of functions as a team at its core. We share resources. We share obviously patients and cases. We're friends together. So it's really an integrated team. And I love managing those complex problems kind of with a partner. That's what really to me makes the biggest difference.
So the next thing I wanted to ask about is what do you think is the most critical skills for trainees that they need to develop early in their training if they want to excel in endoscopic skull base surgery? And what do you recommend for trainees?
I would say that the first key aspect is probably something you develop younger in life, maybe even before you start training. And that's the ability to function as part of a team. So, I think as surgeons, there's to a certain extent, we all have some degree of ego, but you've also got to be able to park that ego at the door and work together for the best outcome for the patient. So I think a really key aspect that you got to focus on is being a team player and also being able to work in an environment where you can take feedback, give feedback, and sort of learn and grow from that. I think that's probably number one. From a surgical skill set, I think you've got to be able to operate efficiently. These are long cases, and if you kind of take your time and dawdle with parts of it that don't matter so much, it's going to make for a very tough and long day for yourself. So you got to sort of understand as a trainee in what parts of the case you can go fast and what parts are really critical and you need to take your time around critical structures, et cetera. So being able to sort of do those things together will allow you to work more efficiently. And in the end of it, develop more autonomy as you sort of progress in these cases being a skull-based surgeon. I think it's also really critical to understand radiology. So becoming an expert at both CT scans and MRI scans to thoroughly understand the radiographic anatomy and then be able to translate that three-dimensionally into what you're seeing in surgery. That's a difficult skill that not every trainee can do well, but it's a really critical one to translate into becoming a great skull-based surgeon.
And just for the next one, what are some of the biggest challenges trainees face when they're finishing their residency and moving into a fellowship program? And what do they have to do to kind of get their skills up to the right level?
Right. I would say the first thing is being very thoughtful in selecting both your residency and your fellowship training program. There are some fellowships that have an amazing skull-based practice and paradigm. They do a really good job training you. There are others who maybe don't have quite as robust of a skull-based program or maybe they're only doing pituitary surgery. And if you're really doing more of the basic things, it's hard then to jump to the next level of doing more complex skull base surgery. So I think initially picking a program that has a very robust volume and complexity of cases is really important. The next part sort of alludes to what I mentioned earlier, and I think as a trainee and as a fellow, if you're develop skills where you can be really efficient with the basics of the surgery, it's going to afford you more time to focus in on those really important complex parts of it, which will then, of course, give you more autonomy and the ability to sort of build those skill sets. The other part I think it's really important is figuring out what that interplay is with the neurosurgical partner you're working with and sort of how you can work together. So what we like to do is early in the year, we sort of train in our ENT fellows more in the ENT portions, neurosurgery fellows on the neurosurgical portions. By the end of the year, we sort of mix those skill sets a little bit so that everyone's a little more comfortable, because when you go to practice, they may or may not have a partner who has the same skill sets they're dealing with in their training program. So having a little bit of that cross-pollination or cross-skill set, I think it's helpful if you get in a situation where maybe you've got to sort of help someone along in building your future practice.
No, I think we were certainly really impressed by that when we visited Pittsburgh, how well you all work as a team, but also the training facilities you offer for all your residency and for your fellows. I mean, the cadaver lab there is fantastic. How important is that cadaver training and simulation training and the virtual reality things you do for training going forwards, do you think, for skull base?
Yeah, I think it's incredibly important. In the 20 years ago, I think it was very expected that someone's first time operating the sinuses in the skull base was like in a live patient. That's not really the expectation anymore. We really, really value the importance of cadaveric training. In fact, for our fellows, they each have a cadaveric training session to go through and to show us their results early in their time to show us whether they're moving in the right direction. So even our fellows who have already had 5 to 7 years of training, the first thing they do is do cadaveric dissections to sort of show where they are and where they, are developing into, if you will. Our residents also, of course, have great cadaveric training as well. We do 3 courses every year, so that's a 4-day long course 3 times a year, where everyone has exposure to those cadaveric specimens and sort of watching both us operate on them and sort of show pro sections, as well as our course participants doing the same thing. So I think it's really critically important, and I think again more and more things like simulation, VR, cadaveric work is really critical to build those basic skills.
Do you think there should be a standardized curriculum for endoscopic skull base or a certification for it?
That's a very good question. Obviously, it gets into a little bit of the weeds of sort of gray zone in certifications, I think. I would say that I don't know that we have that program currently. I don't think it's unreasonable to consider it. We have our fellowships in the States, at least, are sort of run through the ARS, the American Rhinology Society. But that being said, they're actually not like certified to have a quote unquote neurorhinology fellowship. They submit case logs. There has to be a certain number of skull base cases. That number is very minimal. So pretty much every program qualifies for it. That's as good as we have in the States for getting a qualification, if you will. As you can imagine, that becomes a bit of a debate behind the scenes in the ARS as far as how strict you want to make those qualifications. I think that the truth of the matter is, as you get hired out of certain programs, people know what you learn and what you do in the reputation. So that's sort of more of how you go about it. But I think getting a true certification is a bit of a political quagmire, we'll say.
No, fair enough. Tricky question, being on the spot. I'm going to hand over to Ashok, who's going to ask you some more now. Okay.
Sounds good.
Okay. Hi, Garret. It's fantastic. I'm going to take you back to 2023 again. Okay.
Sounds good.
You mentioned that the team working is the key ethos of Pittsburgh team, and should be like any other Skullbase team.
Right.
So when you joined Pittsburgh in 2023, you had experience of working in other departments, but now you're stepping in a larger shoes, and will be walking shoulder to shoulder with the giants. So how did you find that experience? Was it overwhelming? How was it?
Right. So I'll say, to be frank, I've had the really good experience of knowing Eric, Carl, Paul, and George for many years. George and I were co-residents the same year together. Eric's first year on faculty was my intern year in residency. And of course, Paul and Carl were there as well, who helped train me as well. So I've known them, and I've had the good fortune of keeping in close touch with them since I left Pittsburgh. We actually did a lot of research projects together as well. So we kept in kind of lockstep throughout that time. So when I got to Pittsburgh, they were very, very, very welcoming and accommodating. I think it was, a really smooth transition, and all the credit again to Eric, Carl, Paul, and George for helping make that happen. So I think it actually went smoothly. I think sort of that transition back to Pittsburgh went really smoothly. It was very helpful that I had, 6 years of practice already at a major medical institution that, sort of, regardless of when you finish your training, you still build your skills in your career throughout your career, probably till the end of your career. But it was really nice to have those 6 years of autonomy, figuring out how to run multiple rooms, figuring out how to run, complex cases in multiple rooms simultaneously, et cetera. So that really set me up, I think, well. And the transition, I think, back has been thankfully very, very smooth.
Okay, good. And we'll be quite keen to know, how is your typical working day? How does that span?
Yeah, great. It's a great question. So my typical working day kind of goes like this. I'll kind of run through a week, I guess, for you. I usually operate Monday, Tuesday, and Wednesday. And then Thursday is my clinic day, where I see patients in clinic. And then Friday, which for me is today, is administrative day. So today I'm doing a couple different things. Doing this, I have meetings, some research things, and I'm actually recording a radio show this afternoon as well. But a typical day for me is I usually wake up early, and I like to go to the gym before work. So I usually go to the gym pretty early, maybe like 5:45 or something like that. I try to get a quick workout in, and then we start our day. We check in patients for surgery by 7. So Monday, Tuesday, and Wednesday, they start at 7. We run, anywhere from 1 room to potentially 3 to 4 rooms per day. We try to keep ourselves to 2 rooms at a time. And that's, again, where that teamwork comes in. If we're getting stretched thin with a variety of different reasons, we can sort of, have one of our partners come and help us with one of those rooms, which is nice. And then we operate all day long until whenever the cases are done. Sometimes that's 4 p.m. Sometimes that's not 4 p.m. It's whatever it takes we do. And then Thursdays are, again, clinic day, where it's, kind of a busy day. We usually see, I would say, between anywhere from 25 to the high 30s patients, depending on the week. And then Friday, again, I have sort of administrative research day. I occasionally have cases on Fridays. When we do, for instance, fellow interviews, they're usually on Fridays, those kind of things. And we have a lot of meetings and research time on those Fridays. Intermixed throughout the day on every day are a variety of research endeavors where we're meeting with residents and fellows, talking about projects and making those go forward. We have a lot of very specific skull-based things we do kind of each week, which again helps to build our camaraderie and teamwork. So used to be every Thursday in the evening, we had a meeting with our amazing administrator, Mary Jo Tutsko, who many of you guys have probably come in contact with, where the 5 of us and MJ sit down and go through things. We do that now actually on Wednesday afternoons at a slightly different schedule. We have a Tuesday evening film conference. We review all the films for upcoming cases or review of cases every Tuesday evening. We have a case of the week where our fellows will edit and sort of make a very succinct case that we sort of have assigned to them throughout the month. That's on Thursday evening. And then, of course, we do our 4 courses per year, and the good fortune of traveling for other external conferences together as a team as well. So a lot of things we do each week, and then also sort of outside of the usual day-to-day work schedule as a team.
Wow, that's really, really busy. Yeah, but a lot of variety of things, and must be quite interesting. So thank you for joining us, and we're really looking forward to your upcoming talk. So thank you from Kathy and all of our GRN team.
Thanks
You're welcome.
very much.
Thank you so much for the opportunity. We're looking forward to next week as well.
Perfect. Great to chat to you.
Okay.
You too.
All right. Afternoon, everybody, and thanks again for joining. It's really been a fun day doing some live surgery, and then, of course, talks this afternoon. It's been enjoyable to see my partners kind of give their take on things, and enjoy those talks. So again, really appreciate the opportunity to join you. This talk today is really going to be focused on quality of life. So we talk a lot about surgical techniques and things in the operating room. But that being said, to really optimize outcomes for our patients, it's not just about operating room care, but it's also about a variety of things, pre-op evaluation, post-operative care, and those kind of things. So that's what we'll focus on this talk today. As the WHO defines it, quality of life is really a person's own perception of their position in life. It is a broad-ranging concept, if you will. That's important to note because we think of quality of life and what we sort of assess for our patients. But the truth of the matter is, it doesn't really matter what I think about my patient's experience. It really matters what they think about their experience. And that's really where things like patient-reported outcome measures come into play, or PROMs, we'll call them this talk today. And those are really important to assess both disease-specific quality of life, as well as overall or general quality of life. Now, when we think about the skull base arena, there are a number of instruments that are available out there, and it's beyond the scope of this talk today to go through each of those individually. But suffice to say, they're out there, and each one has their own benefits and drawbacks. If you're interested in this, there's a really nice quality of life sort of systematic review that's been done on this. You can see down below that Nick Rowe and I put together. And feel free to look at that if you want to look at individual aspects of these. But in someone who has more of a rhinologic practice and is based on sinonasal quality of life, there are a number of things we think about in regards to quality of life. Certainly, the surgeries that we do affect many aspects of sinonasal function. That's things like nasal obstruction, congestion, crusting, disturbances in olfaction afterwards, and of course, a variety of other things as well. In most people's rhinologic practice, the SNOT-22 is the most commonly collected patient-reported outcome measure. On the call, you guys are all familiar with this. It's a 22-item test, 1 through 5 on each one, with higher scores being worse quality of life, sinonasally speaking, and lower scores being better quality of life. And this can be subdivided into a number of subdomains, which we'll touch on briefly later, including rhinologic, extranasal, ear and sort of facial symptoms, and then psychological and sleep symptoms as well. Now, this PROM has not actually, in its original intent, been validated for endoscopic skull base surgery. That being said, in recent time, retroactively, this has been validated for use in pituitary tumor surgery, so sort of straightforward transcellular EEA. The SNOT-22 score is a validated instrument. And then most recently, just published a few months back, we also validated the SNOT-22 in sinonasal malignancy population by comparing it to the University of Washington quality of life score. So although it's not widely validated across all skull-based surgery, the SNOT-22, which we use in our practice routinely, again, is validated for cellular surgery as well as sinonasal cancer surgery. Now, what does the SNOT-22 score do after endoscopic endonasal skull base surgery? This is a really nice systematic review published by Nick Rowe a few years back. And what he looked at was outcomes in the SNOT-22 and really focusing on 4 groups: cumulative SNOT-22 scores, and then patients who begin with a pre-op score of normal or less than 20, and patients who begin with a pre-op score of above 20 or for baseline sinonasal quality of life. And focusing here on the blue line, this is cumulative SNOT-22 scores. What you see is that after surgery for that first month, scores get a bit worse. They go up in number. But then by 12 weeks, 26 weeks, even out to a year or two after surgery, SNOT-22 scores from the cumulative perspective actually improve and typically actually get better than what they were at baseline. Now, when we look specifically at patients who have a preoperative SNOT score of above 20, so preoperatively they're symptomatic from a sinonasal perspective, those patients almost universally have improvement in their SNOT scores over time following endoscopic skull base surgery. And that may be due to things like getting turbinate outfracts or septoplasty done as part of that procedure. But in general terms, we can tell most of our patients that their sinonasal quality of life actually may improve after surgery in most cases. Now, when you break it down by where the pathology is, this is a little bit of a dichotomy. So blue is an intracranial pathology, and then orange is an intranasal pathology. So like a meningioma versus a sinonasal cancer. And what we see is that at baseline and then at long-term outcomes, folks with primarily intranasal pathology have worsened SNOT scores than those with intracranial pathology. And that makes, of course, some intrinsic sense as we think about that. Now, one of the most important quality of life factors we care about in endonasal surgery is olfaction. And the truth of the matter is the degree to which we will affect someone's olfaction really depends on the location of the tumor and how we manipulate that olfactory mucosa during the surgery. In a case like this, where you're resecting an olfactory neuroblastoma, I expect that patient to have long-term or permanent anosmia following surgery, and they're counted on that, of course, up front. Now, in a case like this with a plana meningioma, there may be a chance we diminish some olfaction, but in general terms, I expect them to remain normosmic for the long term after their surgery once they've healed from the initial insult of the surgery. How do we try to preserve this? Well, as you guys saw earlier today, when we raise our septal flaps, we do our very best to preserve a superior olfactory strip. This is early data from Dan Kelly and Rick Corral showing that with that preserved superior olfactory strip, the rates of objective anosmia postoperatively is quite low with about 5% of patients. And of course, what that superior olfactory strip is indicating, as you saw in surgery today, is making that upper limb incision for your septal flap below the olfactory fila. Then once you reach the head of the middle turbinate coming upwards, where the olfaction has stopped anterior nasal cavity, and preserving in the picture on the right that superior olfactory strip. Now, that leads us to an important next question. Does what we use to make that incision matter? In other words, does using a needle tip bovie to make that upper limb incision decrease olfaction postoperatively? So we sought to answer that with a randomized controlled trial, which we published about 3 years ago. And what we found was that in a randomized controlled trial setting of using electrocautery versus cold steel cautery for the upper limb incision, there's really no difference in olfactory outcomes. That's based both on objective UPSIT scores as well as SNOT-22 questions focused on sense of smell. So in general, we feel very comfortable making those incisions with electrocautery based on that randomized controlled data. Now, what about in larger cohorts or larger series? How do we do with olfaction following general endoscopic skull base surgery? This was a systematic review we published back in 2019, looking at all published data at that point in time. So 29 total studies, the majority of which were really focused on cellar or paracellar pathology. And what we found in this systematic review is that using objective measures of both the UPSIT as well as the CCSIT, or the cross-cultural smell identification test, there's really no difference between baseline scores and postoperative scores in patients who undergo endoscopic endonasal transcellar surgery. We also pulled that data together, and again, there was no difference in long-term outcomes in olfaction from baseline to postoperative outcomes, really suggesting the majority of patients getting cellar surgery, we can preserve their olfaction pretty well. Now, in this particular systematic review, we did not look at pathology directly involving olfaction. We also didn't look at particular harvesting techniques for the flap, but again, we looked at previously with that randomized controlled trial. Now, what about someone who may struggle with olfaction postoperatively? Is there anything we can do for them? This was a really nice study done in both Stanford and Emory in a prospective fashion, looking at the role of omega-3 fatty acid supplementation following endoscopic skull base surgery. And what they did was they looked at, after surgery, patients would get randomized to either saline rinses alone or saline rinses plus omega-3 fatty acids. And what they found was that in the group who got supplementation, there was less olfactory loss at both the 3 and 6 month postoperative time intervals. Now, the degree to which that olfaction was preserved was a very, very small number. So it's limited perhaps, but statistically speaking, at least, there was a difference in outcomes with omega-3 fatty acid supplementation. In addition, those patients with functional pituitary tumors seem to do worse with olfaction than patients with non-functional tumors. So I do routinely talk to patients about omega-3s, and if they're struggling with olfaction postoperatively, I will tell them to at least try this as a low-risk, reasonable thing to do. Again, that's omega-3 fatty acid supplementation. So if we could sort of summarize olfaction data, I would say that a little bit of early olfaction loss is very common, but at least with cellar pathologies, long-term olfactory dysfunction is pretty rare, but really the degree to which we affect the olfactory mucosa is what really matters. And again, maybe a small role for omega-3s in some patients with postoperative olfactory dysfunction. Now, in addition to things like olfaction, there are other morbidities we may cause with endoscopic skull base surgery. One of them to note is the potential risk for external nasal deformities. We don't think about this very routinely, but here at Pittsburgh, a nice study was done looking back at 328 patients. And of patients who did have some degree of external nasal changes, these were patients who tended to be younger, who underwent surgery for cancers, and all patients who had external changes also had nasal septal flap utilization. So something to think about. This was followed up with a prospective study of 34 patients undergoing endoscopic and nasal surgery, followed by a blinded review of and facial analysis. And interestingly, almost 15% of patients report a subjective external nasal deformity, and about 13 of those were also noted on blinded review to have some degree of objective external nasal deformity. Now, all these patients who had that also underwent nasal septal flap elevation. However, none of them planned to undergo rhinoplasty to address it or repair it. Now, I think this has probably changed with our increased use of reverse flaps, which probably provides some extra vascularity to the septum. But I do talk to my patients about this because you will have some who are bothered by this potentially, again, bigger surgeries, flap utilization, cancer, perhaps radiation as well. In addition, I alluded to this today in the case that we did with the encephalocele in regards to vidian nerve preservation. This was a really nice prospective study of which Eric Long was the first author on, done out of Pittsburgh. And this was a prospective study looking at unilateral vidian nerve sacrifice as part of an approach. It looked at both objective tearing after surgery as well as a validated tearing or dry eye questionnaire. And what they found was that in regards to subjective scores, there was really no difference between the vidian nerve sacrifice side and the contralateral side. However, in patients who had decreased tearing preoperatively, there was an increased risk of having worsened validated subjective scores after surgery. So again, the patient we did today who had baseline dry eye, we really did our very best to preserve that vidian nerve because we know really based on this data that she would have an increased risk of issues postoperatively if we sacrifice that nerve. Now, what about septal flap donor sites? We sort of talked about this a little bit today. That, of course, can be an area of morbidity for patients, prolonged nasal crusting, scabbing, and again, maybe even external nasal deformities. So we do use the spyways, as you guys saw earlier today. That does help to preserve that area. In addition, we've tried other things in the past. So this is some data we published looking at placement of a porcine small intestinal site at the donor site, which really improved crusting over time and also allowed some increased progenitor cells to be incorporated in that area. But really what we do nowadays is we use the reverse flap. And we showed that today in the case. You guys can look at that publication, which is shown here. And this really is a very nice way to reline that septal flap donor site. And essentially in every case we raise a septal flap currently, we put that reverse flap into place, as you can see sort of outlined here. And again, those publications are out there if you want to look those up, but a really effective way to improve morbidity and improve quality of life. Now, what about sinonasal cancers? We've talked a lot about endoscopic endonasal cellular and intracranial surgery, but what about when the nose is the problem, when there's really a tumor in the nose? So I'll touch on briefly on some data we've published using the Corsica database. This is a very large prospective study of about 9 centers. And this is centrally enrolled patient data, so both quality of life and oncologic outcomes, as well as central biobanking of tumor specimens. It's really been a really nice initiative for sinonasal cancer. And one of the early studies on this published in 2023 was looking at long-term quality of life after sinonasal cancer treatment. And what you can see here is a couple outcomes. So on the left is a SNOT-22. In the middle is a UW quality of life physical domain, and then the UW quality of life social domain. What we see here is that baseline SNOT-22 scores are actually quite high. So people are really symptomatic at baseline when a cancer is present, but after their treatment, actually the SNOT-22 scores drop quite a bit, as you can see here. So again, long-term quality of life outcomes from a sinonasal perspective are quite a bit improved after therapy. Now with the UW quality of life more of a global scale, higher scores are worse. So they start off pretty bad, they improve and kind of get a little worse over time, maybe radiation effect. But then with their social scores, they generally get worse over time, as you can see here, sort of outline the UW social scores. Now, what factors make that worse? Here we outline The blue line is no involvement of the tumor in the pterygopalatine fossa or the intracranial space. The red line is PPF involvement, and the green line is intracranial involvement. And what you can see across all QOL domains, so the SNOT, the UW physical, and the UW social, is that patients with PPF involvement and intracranial involvement do worse in SNOT-22 scores and both large domains of the University of Washington quality of life score. So those factors do make a difference. In addition, as you can see here, in regards to surgical technique, blue is non-operative technique, red is purely endoscopic, and then green is open, and orange is combined approaches. And similarly, those patients who undergo open approaches tend to have the worst quality of life, both in regards to SNOT-22 and UW physical domains and social domains across the board. And a very nice figure here showing the relative impact of a number of factors here. And you can see, again, open resection, neck dissection, PPF involvement, et cetera. Those are the highest impact factors for the long-term quality of life outcomes you can see sort of outlined here. Now, the secondary question is, if patients have such a poor quality of life at baseline when they're presenting, what factors are associated with it? And this is really nice data, and Dr. Wong was the senior author on this one as well, for baseline quality of life outcomes with sinonasal cancer patients. So we broke this down by the subdomains of the SNOT on the left here, and then of course the subdomains of UW, as you can see here, again, both physical and social or emotional outcomes. And in regards to each of the SNOT-22 domains, what factors played a role for worsened baseline quality of life? And as you can see here, the ones that are sort of bolded are you're going to see listed several times. That's skull base involvement, and then of course perineural invasion and palate involvement. So really important when thinking about baseline poor quality of life is, again, perineural spread of disease and involvement of the palate, especially with speech, swallowing, eating, et cetera. Now, what about the UW quality of life? Well, overall, orbit involvement patients had worse baseline quality of life. And then for both the physical and the social domain, perineural invasion was also a big factor for worsening quality of life, and palate involvement as well in that social and emotional domain. So again, looking at this at baseline quality of life, those factors seem to play a really important role at having worsened baseline quality of life. Now, are there other things we're probably missing out there in regards to quality of life? The answer is yes, I'm sure that there are, and we're a little bit limited with the tools we have currently. But I think we can summarize this data by saying that with general endoscopic skull base surgery, especially in the cellar and paracellular area, most quality of life changes are transient. We can actually maybe expect improved sinonasal quality of life in the long term, and olfactory dysfunction is typically temporary and is at baseline by about 3 months or so postoperatively. There are some unique morbidities based on the approach we do. Again, we looked at vidian nerve, intracranial phosphodiesterase for olfaction, a number of very specific morbidities that are really based on the approach we take in the tumor location. And again, there's some really unique considerations in sinonasal cancer, both at baseline as well as in long-term quality of life. So with that, I'll wrap up. Again, thank you so much for the opportunity. We appreciate it. And I look forward to seeing many of you in Pittsburgh someday, or if not, as we visit many conferences, et cetera, around the world. We look forward to seeing you there. So thank you for the opportunity.
Thanks very much, Garret. That was a really nice talk looking at quality of life outcomes there for our endoscopic skull base surgeons, something that we often forget about, and we're very interested in our life or expectancy outcomes rather than quality of life for our patients. So really interesting to see how you manage it and to see the data that you've got there on the olfactory, and as well as the use of that reverse nasal septal flap. So thanks very much for that.
Stealth Station ENT, the advanced image guidance system for the full range of navigated ENT procedures. Engineered with you in mind, based on decades of scientific, clinical, and engineering expertise, we're expanding what was previously possible with image-guided surgery. Flexible and elegantly designed, Stealth Station ENT streamlines the workflow so you can maintain focus. The flat, under-the-head emitter allows for an efficient setup. Its design allows for a large EM field. Easily find your patient's exam through a variety of network options, super speed USB or optical disc. The visualization and modeling features give you the perspective you need. Leverage data from multiple sources to create high-resolution 3D images. View structures and pathology with high fidelity. Registration expertly matches the three-dimensional positioning of the patient with the preoperative images used for navigation. Patient registration combines registration methods and provides numerical and visual accuracy feedback. Leverage the latest technology for advanced surgeries. See more, do more. The result? You have an image-guided perspective like never before. With Stealth Station ENT, you're at the forefront of ENT surgery. You are Stealth.